All right, so I am providing our didactic today. And we are talking about managing opioid use disorder during a pandemic, because we're in the middle of a pandemic and we have patients who still need us. This isn't, a situation where we can delay care for someone. So maybe you need your diabetes shored up a little bit, but it's been, I don't know, 2 months since I saw you last. I don't need to see you. We can wait. But when you've got a patient who's needing to be seen and managed for their opioid use disorder, telling them that they need to wait and hang tight, with social distancing and not having all their support networks in place because everybody's gone to stay-at-home status, it makes our patient population very vulnerable during this time. So disclosures, actually, when I was doing this, I'm like, I have no disclosures. And then it's like, oh, wait, maybe I should let them know that I actually have a contract with Doctor on Demand, which is actually a telemedicine company. They do not have any brick and mortar clinics. It's all telemedicine. I haven't done any work with them since 2018, but when I was actually going through and making the slides and including one of their logos, I'm like, oh yeah, I should probably tell you guys that I do have that association with what I'm presenting in here today. And then I do have a thing for chickens, and there's nothing cuter than a baby chick. And the stress of COVID and having to work from home and figuring out how to take care of my patients meant that I've been looking at a lot of pictures of baby chicks. And so are you. You're going to get to see some of my baby chicks. These are not mine. These are just pictures. All right. So what we're going to do today is go over changes in requirements. There's some really heavy slides in here, and I'm not going to read them out to you because they're very lawyery in the way that they sound. I've put them in there in their entirety, more as a way for you guys to reference back what probably many of the emails we're all getting are saying. Leveraging these changes to our and our patients' benefit, and then ways in which we can use these changes and the modalities that are available to us to reach our patients. All right, first baby chick. This is actually an Americana. I have one of these. It came to me a little bit older. It wasn't so cute and fluffy.
Hey, Joyce.
Yeah?
I think you have us on the wrong screen.
What are you seeing?
We're seeing your, it's not the actual slideshow. It's the PowerPoint.
Oh, they didn't.
Weird. Oh, maybe I need to share it from that screen. Gotcha. Hold on. Let me grab that one. Thank you. I'm just trucking along here having a grand old time looking at cute baby chick pictures, and you guys can't see a thing.
Yeah, we want our baby chicks.
All right.
You need your baby chicks.
Here they come. We all need baby chicks. There it is.
Yeah.
There's a nice fluffy Americana chick. I'll go back. Those are our, can we go back? Go back. Ooh, can I go forward? Yep, okay. There we go. So those were our objectives. Maybe you could see those before I switched over. Changes in the requirements, leveraging those changes, and then the modalities we can use to make it work. So fluffy little chickadee there. So like I said, some of these slides are really heavy and they have too many words in them. So basically this is kind of a definition of telemedicine, the licensure that we need. Apparently there used to be a way just to have a telemedicine license in the state of Tennessee. They went away with that. And this is like from 2016, October 31st, 2016. You have to have a full license in the state of Tennessee to provide telemedicine. You can't just have a limited license to do it. And then telemedicine is electronic communication. It's got to be secure, HIPAA compliant. You can do the video conferencing, which is what we're doing. There's also, and for those of you who have tons of telemedicine experience, I apologize for some of the, maybe like, yeah, I know that quality of some of this, but the store and forward, basically what that is where you have pictures or video that have been collected and you will send them to a specialist, to your consultant. They will review them and then get back to you. So that's that you've stored the information, you send it forward to the person that you're engaging in an electronic means to provide input on your patient care. So those are all allowed in the state of Tennessee, but what we cannot have count as a telemedicine visit is straight up telephone. We can't do that. So faxing between, using patient portals, those type of things, emails, those are not considered telemedicine, which is an important distinction to be aware of what counted before the pandemic and then what's happening after the pandemic, oh, we should all go get baby chicks because it's springtime and it's a wonderful distraction. Post-pandemic, we can actually use the telephone. So now that is okay for telemedicine. They will allow that to count at this time. So only for the duration of the public health emergency, we data wave practitioners and those in OTPs can prescribe, dispense buprenorphine to new patients with opioid use disorder for maintenance treatment or detoxification following an evaluation via telephone. So prior to the pandemic, this is not something we were able to do at all. So this is a really big change, and it feels kind of weird, I'll be honest with you, being able to not engage with my patients in the way that I'm used to, like sitting in the office with them, getting to know them, getting to know their story. That has been waived. We do not have to have an in-person or even telemedicine where it's audio-visual, video conferencing situation to be able to prescribe for a new patient with opioid use disorder. So that was a change that came down March 31st, 2020. Telehealth policies vary state to state. So if you have colleagues in other states and you're talking to them about what they're doing, and it sounds like a great idea and you totally want to do the same thing, you need to check what's allowed in your state, because what they do in California is not what we do in Tennessee. It's not what they do in Florida or Massachusetts. So it's different state to state. This is a link that I'm not going to hit because it's just a document that has lots of kind of heavy words in it, but to peruse through it and quite honestly discuss these things. If you have a compliance officer at your organization, to discuss that with your compliance officer to make certain that you guys are doing things above board the way you need to be doing them. And even though there has been some loosening, even some of the HIPAA requirements are like, if it gets screwed up during this time, like, we understand, we're all doing our best, and we probably won't prosecute you. So you want to make certain that you're following it and you're understanding the rules and the changes the best that you can before you go implementing them. And that's another thing to toss out there when I say this. This is a demonstration of the information that's been provided to us, and how you utilize it and apply it to your setting will have to be internal decisions made. So I'm providing, that's part of why I didn't summarize the language and why it's all that heavy lawyer-like wording, because I don't want to try and summarize it, because I'm definitely not a lawyer. But I love this little chick because she's just so cute with that little bonnet tied around her head. All right, so clinic visits, in-person office visits may be reduced, because that's what we're doing in this pandemic, right? We're trying to decrease the number of patients coming into our offices because they are going to be exposed to us. Our staff will be exposed to them. We will be exposed to them. So in the desire to decrease the spread of a new coronavirus that seems pretty nasty, we're trying to decrease the amount of interaction between all people, including our patients. But we still need to take care of our patients because they can't wait for this pandemic to be over to get their care. So we can use telehealth to get that done with a HIPAA compliant platform. All the requirements that we would have for an office visit still are there, like checking CSMD. You need to check CSMD before you have your telehealth visit and prescribe their next refill of your medication. If for some reason you can't do what you need to do documentation wise or assessment wise, or you're not able to check CSMD, for instance, like the other day I could not get into CSMD. I put that in my notes. CSMD was not available at the time of our telehealth visit. Or some of the things that I can sometimes see on my visits, like like we had a visit today with a patient on telehealth where I could very easily see that her pupils were the appropriate size. She had icteric sclera, like I could see those things, but some people, their connection, I think they have eyes and they still have two. So, the quality of your telehealth image can have an impact on what you're able to see and not see of your patients and document. So either in office or telehealth, we can send or call in our patients' prescriptions. So buprenorphine is a Schedule 3, which I really feel like sometimes gets forgotten in the world of the pharmacies and the community pharmacies, just because I know they're so heavily regulated that they've got to dot all their I's, all their T's, and then find some extra ones to make certain they dot and cross. But we have always been able to call it in. It's just now it's very well understood that we can call in buprenorphine. And then it's also, if you have e-prescribing in your facility, you can also e-prescribe the buprenorphine. You just have to do that double verification authentication process, which is kind of fun. I've gotten to do that and I actually really like it. So one of the things, and this is coming out of the Tennessee recommendations, is decreasing patients' exposure to the outside world. Like, how many times are you going to make them go to the pharmacy, right? So writing for 28 days, if they're normally being written for 14 days, you can send the 28 days in, but tell the pharmacy not to dispense more than 14 days. So I actually, when this came out, I had a lot of concern about some of the language in what the state of Tennessee thought we should be doing with our patients, and especially in the spirit of trying to not expose our patients and people be exposed to our patients for potential of contagion spread, that sending in a 28-day supply but telling the pharmacy to only give them 14 days and they still have to come back to get the other 14 days seemed kind of self-defeating of the purpose. So I have a number of patients who actually could have been moved up to the 28 days. So that's what I've been doing with them. I have some that are definitely not in that category, but the majority of them right now are getting 28 days just to make certain that they are not going out and exposing themselves and others. So one of the issues, and you guys may be kind of ringing in the back of your minds, like we can't do internet medicine. We can't do it that way because of the Ryan Haight Act of 2008. What that had was you have to have a face-to-face visit with a patient. So I've just told you that the need to have a face-to-face has been waived during the pandemic. So in regard to the Ryan Haight Act, there's an additional exemption for the in-person requirement if the telehealth visit is being conducted during a public health state of emergency. And that's exactly where we are right now. E-prescribing also is not internet prescribing, even though we're using the internet to get this stuff done. E-prescribing is different than that. But just to make it clear and everybody feel like what we're doing is above board, it is sanctioned, it is okay. We are in a public state of emergency as declared by the Health and Human Services Secretary. So we can do it this way. It is okay. And we are not going to get in trouble for doing telemedicine and e-prescribing buprenorphine for our patients. We're in the clear. It is springtime, sunny days are ours. Counseling can also be done via telehealth. So again, HIPAA compliant video conferencing or telephone sessions. I'm not going to go into the whole, like what CMS, those guys, too many initials, and whether they're going to pay the same for telephone visits as they are going to pay for telehealth visits, because that's confusing and kind of a mess, and we're all just waiting to see what they actually reimburse for at the end of the day. But you can just plain old straight up use the telephone to get this stuff done too. If you do not have access to video conferencing HIPAA compliant software, you can just use the phone and get it done as well. Again, with the goal being to reduce person-to-person contact. All the documentation we need to do though still needs to happen. Like in our clinic, we had to create special titled notes, like this was a telephone only visit and denote that, or this was a telehealth where we had video conferencing. I saw them and heard them, they saw me and heard me through the camera on their phone or their computer. So we have notes where we can document just like we would if they were here in person. All right, so all of this definitely has made me feel like I need my mommy and I want to go hide. But the truth of it is we have been given an opportunity with all the changes in the rules to explore a brand new world. And we may find that some of these things that have been loosened, that we realize that we actually can provide quality care to our patients in this environment. It may be something that we want to continue to do and continue to provide, you know, telehealth services and e-prescribe for our patients going forward. So I probably have this slide a little out of order. March 31st, we can do this all by the telephone, even for new patients. So new patients, they don't have to be seen in person. I need to rearrange that slide order. Urine drug screens. Because if you're not bringing patients into the office, how are you going to collect our trust but verify objective sample information? There are ways to do this where patients in some places are doing this. I'm not, and I'll be curious to hear if anybody else is engaged in this, where you can actually send test kits to a person's home and then they mail it into the pharmacy. When you think about it, just in primary care, we do the thing with the little occult blood stool cards or the FOBTIA cards, where they do that at home and then they send it. Usually they'll have them drop them off at the clinic, but you can send those into the lab. Same kind of thing. They're doing at-home testing. Granted, I know the idea of like, well, whose urine did they test? Was it their urine? Was it their saliva when they put it in their cheek? Like, who was doing what and where did it come from? We don't have that kind of oversight and engagement. So there are ways, if you really feel that you need to have documentation of what substances have been in, around, or about your patient, you can collect that, where maybe they come by just for a quick lab visit, provide the sample, and then go back home. And they're not in your office for an hour and a half for a visit and some counseling while they're there as well. Because the more time they're out, the more potential for exposure. From Tennessee, what they want us to do is best as we can, keep on the same schedule with the frequency of urine drug screening. ASAM takes a little bit different slant on it, and I prefer ASAM's approach, that requiring patients to present to a healthcare facility to provide those urine or saliva samples may be more harmful than beneficial, and unnecessarily increasing our patients' risk of exposure. So one of the things that I tend to do in my clinic is when you're here, you're doing some type of screening, whether it's urine or saliva. We're doing a screening when you show up for your visits. So my random is 100% all the time when you're here. So I probably have more than the Medicaids want to pay for on my patients, but it also means that I've been monitoring frequently enough that during this time, I don't feel bad about not getting samples from my patients. For those patients that we're missing telehealth appointments, or they're calling in between, or we're not connecting the dots, I am having those patients come in for a visit to get their refill, because something's not going right. For my patients who are stable and they're doing well, or even patients who are having some struggles and we identify it, if we're able to connect with them through the means of telehealth and telephone, we'll manage it that way. But for those where the dots are just not connecting, I am bringing them in. But again, using the telehealth as a way to engage with patients has provided a really interesting portal into their lives. Like, I know what their housing environment looks like now that I had no idea about before. And I would have to have spent hours setting up and going out for home visits. So I now see kind of the environments my patients are in, and it's provided me with a really interesting perspective. I am going to try and show you guys this. We'll see. I may have to go out and reshare. So ASAM has a lovely response webpage for coronavirus. Yes, I want to do it. All right. Are you guys seeing the COVID resources page? Or are you still seeing the PowerPoint? Okay. Let me stop share. I'll go out and share that screen, because this actually has a number of, are you seeing it now? Okay. This has a number of really good, there's webinars you can get here. You guys already know about ASAM and what a wonderful resource they are, but access to buprenorphine, they have one, adjusting your drug testing protocols. So just talking about that, consider pausing urine drug screens, so you can, there's all kinds of, information you can read here. It's a really great resource that you guys can explore. And again, this will be in the PowerPoint slides that you guys have access to. So using the resources that we have, ways to respond to the coronavirus pandemic and the way in which we're having to adjust our treatment practices. Also on that webpage are counseling resources. There's information about helping your patients connect to virtual support groups. So if that isn't something that's happening in your community, we're lucky to work with Strongwell, and they have a wonderful group of on like Zoom. They're using Zoom to do their online support groups, and they're doing things like macrame and makeup and art and wake up with yoga and all kinds of other types of support groups. So it's not just, you know, sitting on a Zoom page like we are and talking about, you know, your story. You're actually getting to engage in fun activities. So there's lovely resources out there for our patients to feel supported while they're still having to stay separated. Oh, it does this. Hang on. There you go. Oh, and one of the things I really must do if I get chicks this summer is dress them up in cupcake skirts, because that just looks like a ton of fun. So this is what I'll be doing when I'm not seeing patients in clinic, is trying to get my hen to sit on eggs so I can dress up chicks, because I've got to help my brain decompress from all of these changes. So this is actually that page that has the support group information off of that ASAM coronavirus resource page. So here are some of the different ways in which we can use technology to engage in our patients so that we are keeping them out of the office, we are keeping them engaged with us, we can see them, they can see us. So the link here is actually to the top telemedicine apps of 2020. So telemedicine has been something that's been coming, and coming. Some people may have already engaged in telemedicine services in their OTP or OBOT or just routine primary care environments. But it's with this opportunity that we have been pushed into with the coronavirus issue. A lot of us are using telemedicine that never thought they would use it. Some of us are finally getting an opportunity to say, guys, we should have been doing this for a while. And these are some of the platforms that exist. Doctor on Demand, like I was saying, I have a contract with them, but I haven't worked with them since 2018. They are an all-in entity, so it's not something that you can contract with them and pull that into your existing clinic. It would be an outside of the work that you do, and actually they don't do any controlled medication prescribing at all, so it's not one where we would engage with MAT services. Doxy.me is one that you can just use. You don't have to have a separate contract with them, like outside of your clinic practice. You can contract with them to bring it into your clinic practice. Visual, same thing. That's the one actually we're using. Don't ask me for my opinion on it. The one that shows you like the face of a telephone, and some of you guys may do this already when you're calling your patients, it's the Doxy dialer. For some of us, apparently, have managed to accidentally, luckily, fall into a beta test group. I think it's anybody who has an iPhone. So I can actually use the Doxy dialer to, to video conference with my patients. So I can put in their phone number and it will send a text that shows the number of my clinic. They click the link in the text and they're able to open it up, and we are engaged in a video conference, their phone, my phone, that I didn't have to do any fancy setup for. So that's an option. Zoom, HIPAA compliant Zoom, there is that platform as well, that you can use Zoom to have your video conferencing. So there are a lot of different ways to get it done. I've also heard of like Microsoft Teams. I think you can do something through that. I have a colleague who's using that. Some of the EMR companies have telemedicine built in as an option. So you probably have to shell out some extra cash to get that going for you. But there are lots of different ways to utilize, because everybody's coming online now, right? Everybody wants to have a telehealth platform. And so there are tons of companies out there who are more than happy to help you make that happen. All right, so telehealth versus telemedicine, forget it, trying to figure out what the difference is between the two, because everybody has different definitions. Telehealth, though, seems to be used more commonly as a broad term to include all of these things, like the store and forward, where you can collect information and then send it to your consultant. There's where some people, especially in rural communities, may have seen, where you've got the doc on the with the little boy in that picture that you guys are seeing. The doctor is actually the man on the screen, and this is a facilitator in the clinic that's putting a special device up that is sending the image of the little boy's oropharynx to the doctor who's looking at it. So that's a way to provide telemedicine, where your patient is in a clinical setting, the doctor is in a different clinical setting, and you provide telemedicine services that way. So with the pandemic and trying to keep people out of offices, the way that we're seeing it more is the picture down in the lower right corner, where you can tell your patient is at home, your doctor is in a casual setting. So, you know, nobody's in an office type situation. The doc maybe, or the provider on the other side, maybe in a clinic setting, but they're going to be in a room with the door closed. It's not like they're sitting in a busy office with people going around and behind them. These actually are my birds. The one that you can see in the front that looks more like I'm raising vultures than chickens, they're 6-week-old pullets and they're not cute. So this is Felicia, the black one, and then we've got Wella and Goldie. So Felicia, just like, you know, I'm got an Americana because I wanted to have blue eggs, right? That was my business plan. I'm getting blue eggs. We'll get some brown ones from the others, that's fine, but I definitely want the blue eggs. And I did. I invested in this plan. I spent extra money to make sure, and I had a female bird to lay me blue eggs. So sometimes plans do not always go the way that we planned for them to go, and you may end up with something else. So right now we're in a situation where tons of rules, tons of laws have kind of been quickly pushed down and changed. It does not mean they're going to stay that way. It does not mean that we are going to see things stay exactly as they are. Are they going to go back to the way they were 100% before? Or is this an opportunity to, knowing that we've been given a different opportunity, collect information, provide data, give feedback, connect with those people who make the decisions on a state level? What we're doing is actually really good for our patients. I can reach more people this way. I can engage more people in services. Being able to provide telehealth services to my MAT patients means a whole nother level of accountability and graduation of, you're doing great, your recovery's online, you know, you don't have to come into the office, we can do telehealth visits. So it's a brand new opportunity to change the business plan, because that is what I had to do with my business plan, because Felicia had to be renamed, is now Felipe, and I'm hoping that I get some chicks that maybe I can dress in cupcake skirts and they will grow up and lay me blue eggs. So sometimes we have to change what our plans were. But as we gain knowledge, as we have more information and we feel more comfortable and confident with the work that we're doing, the better off we are. So that's where we land in this pandemic. I actually did a quick edit last night of my slides, and I was going to show you a beautiful picture of Felipe because he is a gorgeous rooster. But unfortunately, that's not the slide set that I pulled up. So you don't get to see Felipe as a grown-up, beautiful bird, just as his ugly little pullet, non-pullet self. But that is the end of this slide set.